Today and actually next Monday, we're going to talk about dose response. So we're going to be switching away from some of the molecular details and cellular information that you've had the last couple of lectures. And this is all about evaluating how much drug to give to an individual, what is the correct dosage, and how do people respond to different dosages of drugs. How can we compare one drug to another? And so certainly a lot of the focus of this is going to be on drug potency and drug efficacy, which are two different things. And potency is basically how strongly a drug binds to its target, and efficacy is how well it works biologically. So today, we're going to talk mostly about how you evaluate an individual drug for its potency and efficacy, and how that would work in an individual patient. And then on next Monday, we're going to talk about how drugs behave in entire populations of individuals, a whole cohort of patients. So this is kind of individually based today, and then on Monday, we'll look at some similar approaches, but apply them to whole populations, which is the sort of thing you encounter in clinical trials and when a drug is released on the market and is used to treat, thousands of patients. Okay, so dose response 1, here we go. The most basic thing we can do, and this is actually fairly simple, straightforward stuff today, but I want you to think a little bit about what a dose actually is. And from a medical perspective, you could define it as the amount of drug given at a particular time with the idea that you're going to achieve a desired pharmacological or clinical response. And that's kind of a medical view of it. But in terms of a biochemical definition, a dose is the amount of drug necessary to be given that will achieve a desired concentration at an active site, a target or a receptor, okay? So kind of two different ways to look at it. So that's what a dose is, but it's worth considering what is a response. So a response is obviously what happens when you give the drug, but the response can be measured in a great number of different ways. And it could be in terms of the clinical aspect of it, how well it works to alleviate a disorder of some kind, or it could be something more biological. So we almost have to define what a response is in order to talk about this. And to do that, we need to determine what endpoints are. What is our desired outcome? So endpoints that can be measured and described include the following. It could be physiological. So for instance, the amount of drug necessary to lower blood pressure by, 10 bars of mercury or whatever. It could be biochemical, the amount of drug that is needed in order to change something that we can measure biochemically, like the amount of glucose present in your blood. We want to lower it by a certain amount in order for it to be effective. Now, both of those have a lot to do with knowledge of the disease that you're treating, right? So you'd have to be guided by information on the particular disorder. So if you want to reduce blood sugar, how much blood sugar reduction actually would achieve an effect that's desirable. So it becomes medically informed. Other endpoints we can look at are toxicological. We're basically talking about adverse events or side effects. And there, if we're doing endpoints that are toxicological in nature, how much toxicity is allowable? What is a reasonable amount of toxicity? And there are such things as reasonable amounts of toxicity. If it's a psychotropic drug, we might want to, the endpoint might be behavioral. How much does it reduce patients' depression on a questionnaire-based assessment. And oftentimes behavioral aspects can be turned into numerical values. And so we really want these endpoints to be measurable, something we can actually put a number on. And you can think of many other things. So endpoints are basically driven by the medical outcome and sometimes by the side effects. And typically in a study you'd measure both of those things. So the study endpoints should be something that are measurable. They should be parameters that can be measured. Like for instance, change in blood pressure is physiological. Change in ligand receptor occupancy, that's biochemical. Toxicological, you might draw serum from the patient and look at liver enzymes like ALT, for instance, and determine how much liver damage is being induced at different doses. Behavioral depression scores can be numerical. So we also want to determine other features, and this gets really more into the populations, but bear in mind we want to know what's the relationship between the dosage and a major adverse outcome, which is death, of course. We might want to measure how much the treatment improves the condition, toxic effects. So those are all population-based. But you get the idea, we have to have some way to measure these things and describe them in order for this to be a valuable exercise. And a lot of these things are worked out in animals. So for instance, what a lethal dose is, we might work that out in animals. Obviously, we aren't going to figure that out in a clinical trial with humans. And sometimes it can be very hard to relate animal findings to what happens in humans. That's why in clinical trials managed by the FDA, the very first thing they assess in phase 1 trials is the safety of the drug. Okay, so what happens to the drug in vivo? What are the effects? We want to consider pharmacodynamics, and remember that is how drugs work, their modes of action, MOAs. In vivo, we also would be measuring things like pharmacokinetics, how much the drug builds up in the blood, what are the relative impacts of a dose on absorption, distribution, metabolism, and excretion. That's ADME. Also, bear in mind that we're trying to figure out how given dosages work, but not all humans are the same. There's a lot of genetic variation between different individuals, and that's going to affect ADME and dosing. So for instance, there are a lot of very common genetic variants in the genes that encode CYPs, cytochrome P450s, and those are the enzymes that metabolize drugs. And so as many as 10 or 20% of the patient population may have differing CYP expression based on their genetics as compared to most people. So CYP genes are very highly variable. Other considerations, differences that are genetic in nature, differences in patients' abilities to transport drugs across membranes, the activity of their transporters, and the like. So let's get into this a bit more. I want to remind you of something we talked about before, receptor occupancy theory. And this occupancy theory really ties into dose response considerations. And of course, the basic concepts, you already know this, but the affinity describes the strength by which the drug binds to its receptor. And it can be measured in KD, for instance. Remember, the lower the KD, the stronger the drug binds. And so we're interested in affinity, and the affinity directly relates to the potency of the drug. But we're also interested in efficacy. How well does that drug work on one of these measurable parameters like blood pressure or blood glucose, etc. So both of these things are of interest. So once again, receptor occupancy, we've talked about this before, but you have a free drug and a receptor, and they get together and interact. The drug binds to the receptor, and you have a drug receptor complex. That's great. And so that is more of an affinity consideration there. But then once that drug binds the receptor, all the stuff happens in the body and you get some kind of a desired effect, or you might get an undesired effect. And of course, this little arrow here is a lot of stuff. It's what happens downstream of receptors, it's signal transduction, it's how the cell changes, it's how that cell alters its function in the context of an organ system, and then finally the whole body. And so occupancy theory, though, kind of proposes that the intensity of the effect that you get out of a drug is going to be in some way proportional to the number of occupied receptors. So here's an idealized case where you have 25% occupancy. So you might get some sort of an effect at that particular dosage that yields 25% receptor occupancy. If you had another case where you get 75% receptor occupancy, you should get more effect, right? So the more occupancy, the more effect that you get out of this. So now here's our first look at a real dose response curve. And what we've done in a study is, and this could be done in mice, for instance, could also be done in humans. But what's happened here is that in several different trials, we have dosed different amounts, okay? And so we can measure the dose by the concentration that's achieved, for instance, in the blood. 10, 20, 30, up to 200 in this case. And then we have to measure some kind of a response. In this case, it's the change in heart rate. So this drug obviously increases heart rate as you add more drug. And what you'll find is that the more drug you give, the more concentration you achieve with a dose, the higher the response. And if you think about receptor occupancy, say this drug binds a receptor, without the drug present, there's zero occupancy. And then at some point, you have partial occupancy levels. And then at even higher doses, all the receptors become occupied, okay? And this line right here describes the relationship between the dosage and the effect, in this case, change in heart rate, okay? So this is a linear scale, so you get this kind of N-shaped curve. And at some point, you reach, well, at higher levels, you reach maximal efficacy, which we call Emax, and you can't go higher than the highest level measured, okay? That's maximal occupancy up here, and all the receptors are occupied. But at some point, you get half maximal efficacy. And if you draw a line down from that and find the dosage that gives you a half maximal response, we define that as EC50, the effective concentration at which you get 50% response, okay? So that EC50 value is a very nice thing to know because it allows you to put a number on the effect of that drug. How much drug do you need to get a response that's halfway to the maximal level? So EC50 is a very important number to determine. A couple of other things to mention here. This is a nonlinear response. It's not a straight line, and most drugs behave this way. So at very low levels of increases on the left side here, small changes in the drug concentration, the dosage, make for large changes in efficacy. But as you get out here, small changes in drug concentration have very little effect, okay? So in an idealized world, we would think that, half receptor occupancy should be EC50. But in the real world, it doesn't really work out that way because, there's just so much going on biologically that that principle doesn't really hold up. But it gives you an idea. I just want you to be thinking about the dose and the response in terms of receptor occupancy. Because it is true that even though EC50 doesn't completely correspond to half maximal dosing in most cases, it is true that as you increase the dosage, you get more response. But it's going to be in this nonlinear way. So, we have to think in terms of potency about ligand receptor equilibria. And you've seen stuff like this before, where you have the ligand that's added to a system where there are receptors present, and you get ligand receptor complexes. That's binding of the ligand to the receptor. And so there's a forward rate, K plus 1, and then there's a reverse rate of dissociation, that's K minus 1. And there's an equilibrium between these two things. And so once again, from such studies, you can determine the dissociation constant, which is the free ligand concentration times the free receptor concentration divided by the concentration of the ligand receptor complex. And incidentally, that's equal to this dissociation rate divided by the association rate, okay? So drugs with high affinity have low dissociation constants, oftentimes in the nanomolar range, sometimes picomolar. And once again, the lower D means higher affinity. So that's basically review. Let's get into this in a little more detail. So here is some other stuff. Once again, EC50 is defined as the concentration of drug that gives you 50% of the maximal response. But be aware that we can also take this x-axis and take the log of the concentrations, and you'll go from that N-shaped curve to this sigmoidal shaped curve. And the reason you oftentimes see dose-response curves presented with the log scale on the x-axis is that it makes it easier to figure out what the EC50 is, basically. You can visually represent the data more easily and see what's going on. But any good dose-response curve yields two very important statistics, the EC50 and the Emax. And so if you know the EC50 and the Emax for a drug, you know a lot about how that drug behaves, and you know a lot about how dosage interacts with or determines the efficacy. And this is just showing you that this is exactly the same data. Here we have linear on the concentration x-axis, and linear on the y-axis, which is the response. Here we've just log transformed the concentrations. We've taken the log of all the concentrations, and now the line looks like this. Okay. So, the efficacy can be anything that you're measuring. It could be how well the drug works, but you could also measure toxicity. You could get specific changes in blood pressure, how much percent microbial death you have in case of an antibiotic, anything you can measure. And so, this is just basic math, but if you look at the dose response curves that look like this, you'll see that the drug concentrations down here are indeed linear, 20, 40, 60, 80. Every tick mark is 20, I guess this might be moles per liter or something. But here we've log transformed, and so you can see that there's a 10-fold difference between each of the tick marks. So 1 is 10 times larger than 0.1, and 10 is 10 times larger than 1, and 100 is 10 times larger than 10. So each log scale difference, order of magnitude, is 10-fold. So if you look at this dose response curve, and here's a linear one, there are at least 4 different things that you can measure. We've already mentioned, the EC50 and the Emax, but there are some other things that you can learn. The first one is the threshold response. So that's the first drug concentration where there's an effect. So this drug here has essentially no threshold value. As soon as you start adding drug, you start to get some kind of a response, okay? But you could imagine other cases where you have to get over a certain concentration of the drug before you see anything at all. And if that were the case, the intersection of the line would hit the x-axis at some positive value. So maybe you have to get to 10 before things start to go up, okay? And that's pretty common to see a threshold effect like that. The maximal response, here we're using change in heart rate again. The maximal response, Emax, has to do with the maximal, it's really the maximal efficacy you'll get out of it. And it's the point at which adding additional drug doesn't give you any more response, basically. Now the EC50, number 4, has to do with the potency of the drug. What's the affinity of the drug for its target receptor, for instance, okay? So smaller EC50s means a more potent drug, basically. The last thing I want to mention, though, is the slope of this line. And you'll see that since this is nonlinear, down on the left side here, where you have lower dosages, just tiny increases in the concentration of the drug give you a big change in the efficacy response, okay? The response. But when you get out to the right, a similar small change might not give you much of any effect, okay? So that's a very important thing to remember, that dosing is not linear. So, if you have a patient that's getting a pill containing milligrams of the drug, and then maybe they're not achieving the desired effect, it may not be the right thing to just double the dosage to 20. Because if that 10 mg is down here, doubling the dosage could change the effect 5-fold or something like that, right? Whereas if that 10 mg is out here to the right and you go to 20, it makes very little difference, okay? So know that, in real life, when you're changing the dosage, you're not necessarily going to get a linear response. In fact, usually you will not. And so that's very important. But that's kind of a common human misperception. If one pill doesn't work well, 2 pills should, right? No, not necessarily. If we're talking about toxicity, that could be quite dangerous. So anyway, the slope is very important. It tells you that there is not a linear relationship between the dose of the drug and the response. Okay, so I guess we just kind of said that, but the slope in a particular region, that's actually the instantaneous value. It's kind of like a number. The slope is a number that tells you how sensitive the response is to that particular dose. So the sensitivity to a change in dose basically decreases as you go rightward on this, okay? So a steep slope means that a small change in this region will give you a major change in the effect, and out here to the right, a similar small change where the slope is shallow will give you only a subtle impact on the effect that you get out of it. Okay. So, drug potency, let's get into, we're going to now talk more and a little bit more in depth about potency and then about efficacy. So, drug potency and efficacy, these are considerations that can actually guide how you prescribe drugs to people. So remember, EC50 is really a number that talks about potency. It's a number that has to do with how tightly that drug binds to its target. There's no regard about, necessarily how good of a drug it is, but it's just what the affinity is. So here are 2 drugs. Here's a dose response curve for 2 drugs. They're both agonists. And drug X has this kind of beige colored curve. drug Y is this purple colored curve. And you can see that you get to the EC50 value, the half maximal response for drug X at lower concentrations than you get to the EC50 for drug Y, okay? So drug X has a lower EC50 than drug Y. So based on this comparison of two different drugs, looking at the same effect, we could say that drug X is more potent than drug Y because it has a lower EC50, okay? Now you can tell from the shape of the curve that this is a log scale on the x-axis, right? So actually, since it's log scale, if this is 1 and this is 2, that means that drug 1 is actually 10 times more potent than drug 2. Drug X is 10 times more potent than drug Y, okay? So that's all about potency. So we're comparing the relative potency of two different drugs here. Now here is another example, and these are two different drugs, but we're also calling them X and Y. For drug X, it goes all the way up to a value, the effect goes all the way up to a value of nearly 100 at higher dosages, whereas drug Y only gets up to about 50-ish, okay? So in this case, now we're talking about efficacy. We can say that drug X has higher efficacy than drug Y. That means it probably does a better job of treating something. You know, it has higher efficacy. Okay. So this is something that's quite important. Really know the difference between potency and efficacy. And usually it's efficacy that's going to drive the choice of which drug is best, not potency. Okay. So, potencies are simply the amount of drug you need to produce a given effect. Once again, potencies are expressed as EC50s, and that's just the amount of drug you need to get 50% of a maximal effect. So here is another example. We have two drugs, drug A and drug B. Which one's more potent? What do you guys think? A? Yeah, A is more potent. Which one has better efficacy? Or is there one that has better efficacy? They both get up to 100, right? So they both have similar efficacy, right? So both drugs could give you a great treatment effect because they go up to 100, right? But here you have to add less drug A than drug B in order to get on the road to higher efficacies, right? So these drugs differ in their potency, but they have the same efficacy. Make sense? So in terms of potency, another way to look at this is that, the smaller EC50 values indicate higher potency because less drugs are required to give you a given effect. Okay, so I don't think there's too much more to say about that one. So here is some real life data where we're looking at two different drugs that can relieve pain. And we're looking at morphine and meperidine. And so let's evaluate that. Which one's the most potent? Somebody want to take a stab at it? How many people vote for morphine? Okay. Wow, the voting thing works. Okay. How many? Okay, so that is the right one. Morphine is more potent. So which one? Then they're both efficacious, right? If you give enough of either one, you'll achieve a great degree of pain relief. Okay, it's just that you have to give more meperidine in terms of number of grams than morphine to get to that effect. So actually, potency has very little clinical significance. We're really more interested in the therapeutic effect that you can achieve. So the most potent of the two drugs is not necessarily clinically superior. So low potency is only a disadvantage if the dose is so large that it causes side effects. That's one reason. Otherwise, if it doesn't cause side effects, who cares if you have a larger pill, right? But the other thing is, sometimes with certain drugs with lower potency, you have to give so much of the drug that it's hard to administer. So you can't fit enough into a capsule or something. It gets huge. It turns into a horse pill, It can be a problem. This is especially with drugs that you swallow for your digestive tract. So sometimes, there are examples of GI drugs where you have to mix a whole bunch of powder into, a glass of water or something. And if you have to achieve efficacy, maybe you have to dissolve like 50 grams of this drug into a glass of water, and it's just nasty, and it's more a delivery problem. Okay, so therefore that would be a case where maybe something more potent would be helpful. So sometimes higher potency is good, but it's only in the case where, a less potent drug tends to cause side effects because you have to administer so much of it, or you just can't physically cram enough of the drug into a capsule or into something you drink or something like that. So then the potency might be a consideration. But in general, efficacy is usually what drives choice of what to prescribe. So yes, morphine is more potent than meperidine on that case. Okay, so drug efficacy. Let's get into this. Once again, the effect of the drug depends on, in some way on what the concentration of the drug is at the receptor site. And that's determined by the pharmacodynamics, usually just by the affinity of the drug for the receptor. So, one of the things that you'll see sometimes is it makes the point that this is a graded effect. That means it's gradual. The word graded gets applied to a lot of these dose response curves and stuff. And that just means that, it's a nonlinear effect mediated by, small graded gradual changes in dosage. So here is another kind of example here, but here we're talking about efficacy. So once again, this thing we can measure, Emax, maximal efficacy, that's the ability of the drug to elicit a desired response, usually because it interacts with the receptor or something like that. So efficacy is far more important than potency for evaluating the therapeutics of drugs. So here are 4 different drugs called A, B, C, and D. A gets you all the way up to 100% response. B gets you up to 80%, and then when you add more, it just stays there. C gets you up to around 50, and D gets you only to about 5%. So if you look at all these drugs, A has the highest Emax, okay? So it's the most efficacious. It gives you the best biological clinical response. Interestingly enough, on these graphs, if you were to calculate the EC50, they actually have similar EC50s, and therefore similar potencies, okay? But even though they have the same potencies essentially, A is a clear winner in terms of efficacy. So once again, it's another illustration of why efficacy usually drives the prescribing or the choice of which drug to use as opposed to potency. So efficacy can also differ between different tissues. So here we're looking at a drug in two drugs in two different tissues, norepinephrine and oxymetazoline. And you can see, and this is one that's done in rat, so in different muscles and in the vas deferens. But anyway, two different tissues. And you can see that here's a dose response curve. And so in muscle, both of these drugs have a very similar dose response profile. But if you look in this tissue, one of them has very good efficacy and the other does not. And so this is actually kind of how you have to think about things in the real world, because you have to think about the organ system you're treating. So for instance, if you're looking at, instead of efficacy, let's say we're looking at side effects, and we have cardiac muscle and skeletal muscle, for instance. Say we want to have something that would relieve spasms in skeletal muscle. We would like that drug to work better in skeletal muscle than in the heart, right? So that's a very important consideration, because you don't want to induce cardiac side effects when somebody has like muscle spasms in their arms or legs or something. So, and that's just a feature of the drug. It really has to do with the pharmacodynamics of the drug, how it works. So, few more examples. And this is just to kind of get you familiar with all of this. These are all like analgesics that cause pain relief. And so here we're looking at dose response, and this is just data actually collected in a lab. So it doesn't fit perfect curves because we've got too few points. But we certainly have increasing dosage in terms of milligrams versus the amount of pain relief using a pain index. So the higher this number, the more pain relief there is. And we're looking at morphine, ibuprofen. APAP is actually acetaminophen or aspirin. And so higher numbers mean more efficacy, right? So you could look at data like this and say, and from this simple data here, you can talk about the relative potencies and the relative efficacies in the comparison of these three different pain relief drugs, okay? For some reason, they've kind of, let's just consider this to be like Tylenol, acetaminophen. So which one has the higher efficacy? Who wants to vote for ibuprofen or aspirin and APAP? Morphine, higher efficacy, absolutely. Which one's the most potent? How many people would go for morphine? Yep, it's the most potent. So in this case, morphine is the most potent, but importantly, it's the most efficacious, okay? So it has the highest potency and the highest efficacy. And yet, most people would say it's probably safer to prescribe like ibuprofen or Tylenol than morphine, correct? What's the problem with morphine? Addiction, right? There's more to the prescribing. So you could consider addiction an adverse event, I guess. These ones down here have almost no chance of addiction. So that's really, if you wanted to do a different dose response curve, but in this case, instead of putting pain relief on the y-axis, we put strength of ability to cause addiction, these two would come out safer than morphine. So it's, potency and efficacy are not the only considerations for prescribing. We really have to also think about toxicities and problems, unwanted problems. So yeah, morphine's the most potent and the most efficacious. Here are three stimulants. We have methamphetamine, D-amphetamine, and caffeine. And here is how much stimulant activity you get, going from 0 up to maximal, and the dose. So Who thinks that methamphetamine and D-amphetamine have similar efficacy? Yeah, absolutely. And caffeine has less efficacy. Okay. Which one's the least potent? Caffeine? Because if we figured out the EC50, it would have the largest, concentration for EC50. Yeah. Another thing interesting that you can see from this is incidentally the threshold effect that we mentioned earlier. So this means that you can drink a certain amount of coffee without experiencing any stimulation, and then if you get over a certain amount, you start to see the effect. Like if you drink a half a milliliter of coffee, that's not enough to wake most people up, right? You want a whole cup of coffee to get something going on for you, right? And so there's a threshold effect on these. But the threshold effect for methamphetamine is very small. There's a little bit of a lag, but it really takes off pretty quickly. Whereas you have to get a certain amount of coffee before you feel anything at all, okay? So, yep, you guys had it. If we look at potency, they all differ in their potencies, and methamphetamine is the most potent. Caffeine is the least. D-amphetamine is somewhere in the middle in terms of potency. But if you look at efficacy, methamphetamine and D-amphetamine are both equally efficacious, and caffeine is least efficacious. And that's why caffeine is not a controlled substance, okay? So here we have more opiates, and we're comparing now what? 7 different drugs, and they're all opiates, or most of them are. These aren't, but at any rate, you can look at these. Which one do you think is the most potent of all these? Looks like morphine is a winner again, huh? Which is the least potent? That would be this guy over here, salutaridine. Okay, which one's the least efficacious? That one as well, right? So if you look at all these data, morphine is the most potent. You can see that because the curve itself lies farthest to the left. Salutaridine is the least potent because the curve is further to the right. The EC50 is further to the right. But in terms of efficacy, it's kind of interesting. All 4 of these drugs, the first 4, are equally efficacious. These ones over here have intermediate efficacy. That's codeine and thebaine. And this one here is the least efficacious, the salutaridine. So hopefully, all of this seems kind of simple stuff, but I hope that you can really get the distinction between potency and efficacy and know how to interpret these graphs and understand what it means. If I just tell you the potency of a drug, you have no idea of how well that drug works. All you know is it has a high affinity for a receptor. You don't know how well that drug works. But if you talk about the efficacy of a drug, and you know that it's been tested and proven to do something useful, that's really what we're looking for. And you also know that potency generally isn't that important, except when you have situations where the least potent drug actually causes a lot of side effects, or it's really, really hard to deliver because it just takes so much of it. Okay. So once again, just a little bit of review here. Agonists, antagonists, and inverse agonists. I guess I want to say a little bit more and define these a little more carefully so you know. But agonists are drugs that trigger the normal response that's ordinarily mediated by that receptor. Okay? So they basically activate the receptor, and the receptor, the function you get out of that is whatever that receptor ordinarily does. Partial agonists weakly trigger the normal response, when they bind to a receptor. Antagonists actually compete with the agonist, so there we have competition going on. But that reduces the response that you get. And then inverse agonists, these are the really weird ones. They trigger a response that's opposite of an agonist type response. And those are more rare, but they do exist. And so once again, we can now look at these in terms of dose response and think about, agonists, partial agonists, inverse agonists, and think about them in terms of dose response. And this is a perfectly good dose response curve. We're increasing the concentration of the drug on the x-axis, and we're looking at how much response you get on the y-axis. And so here is the full agonist. Basically, it's the winner. It gets you the most response, the most efficacy. A partial agonist is here. And this is a placebo, a compound that's not active. Whereas an inverse agonist actually gives you the opposite physiological effect. Okay. And so you've seen these before, and we've talked about why, how they work. We've talked about competitive antagonists, for instance. You know that they compete for a binding site with an endogenous ligand of some kind. But this is kind of how you can evaluate them using dose response curves. Okay. So, here's some more example questions. And these are the kind of graphs I might ask you to interpret, for instance, on a midterm exam. But, you get the idea. Here's a bunch of cannabinoid receptors. It's one different compounds, one cannabinoid receptor, CB1. And so here's dose response. Which one could be considered, which ones are agonists? Agonists have to go up, right? But, the most complete agonist, what do you think it would be? 2-AG? Yep. How about arachidonic acid actually activates CB1 cannabinoid receptors? If this is a full agonist, what would you call arachidonic acid? Partial? Same with anandamide. How about this experimental drug DIM? That would be an inverse agonist, right? So yeah, you look at this, we got a full agonist, 2 partial agonists, and 1 inverse agonist. And you should be able to distinguish those. Incidentally, we always call the agonist the drug that works best. Well, you discover a new drug that takes it to a higher level, and now we call that one the full agonist. And the former full agonist is now a partial agonist. So it's only in comparison, drug-drug comparisons, that we can get this out. Okay, so we're a couple minutes early, but like I said, that's a fairly simple, this is very different than the molecular stuff, not too difficult. And you got the basics for dose response curves now. It'll get a little more complex on Monday because we're going to start looking at populations of individuals and how populations respond instead of case by case like this. All right, you guys have a good weekend. And I will post this video shortly so that you have it, because I know you're going to study all weekend, right? Anyway, we'll see you later. Bye-bye.